Epilepsy. Definition. It comes from the Greek word epilepsia, which means taking hold or seizing. It's a disorder characterized by recurrent seizures. Recurrent transient attacks of somatic, psychic, or autonomic clinical features. It represents clinical features of abnormally hyperexcitable cortical neurons resulting from paroxysmal and excessive electrical neuronal discharge associated with EEG changes and maybe of disturbance of consciousness. Etiology. Some causes of convulsions, idiopathic and secondary. Idiopathic epilepsy, it is the most common cause, 65%, may be associated with positive family history in some cases. It starts in the first and second decades in the form of grand mal, petit mal epilepsy, myoclonic and atonic seizures. Secondary epilepsy, local causes in the brain, congenital, cerebral palsy, traumatic, cerebral contusion or laceration, inflammatory, encephalitis, meningitis, brain abscess, neoplastic, brain tumors, degenerative, presenile dementia, vascular, stroke, hypertensive encephalopathy, and the stroke is especially hemorrhagic. General causes with secondary effects on the brain, toxic, alcohol, cocaine, lead, botulism, tetanus, iatrogenic, lidocaine, iron H, ambihylar, amphetamine, and aminophylline. Metabolic, increased glucose or decreased glucose, increased calcium or decreased calcium, increased sodium or decreased sodium. Endocrinal, hypoparathyroidism, hyperthyroid crisis, organ failure, hepatic failure, renal failure, heart disease, Adam's stroke attacks, and phallocytology. Nutritional, pellagra, vitamin B6 deficiency, physical, high fevers, heat stroke, and finally hysterical. Clinical picture, generalized seizures, excessive electrical discharges from the cortical neurons in both hemispheres simultaneously, grand mal epilepsy, attacks of tonic-clonic convulsions, pre-ectal stage, ectal stage, and post-ectal stage. Pre-ectal stage or aura, warning sign of coming attack. It may be somatic, myoclonus, paresthesia, psychic, hallucinations, autonomic, tachycardia, and sweating. Ectal stage, which is the seizure stage, sudden loss of consciousness for seconds, 2 minutes. Tonic phase, few seconds. Upper and lower limb are extended. The head is retracted to one side and eyeballs are rolled up. Jaws are firmly clenched with biting of the tongue. Cyanosis due to impaired respiration, and there may be incontinence of urine. Clonic phase, few minutes. Upper and lower limb contract and relax repeatedly and rapidly. Head jerks forcibly. Post-ectal stage or sequelae, it may be somatic, thoughts paralysis, less than 24 hours due to neuronal exhaustion. Psychic, confusion, autonomic, vomiting. Drug of choice, carbamazepine or phenytoin. Petit mal epilepsy, attacks of loss of consciousness, absence. It starts in childhood, improves at puberty, and disappears at the age of 20, not preceded by aura, not followed by sequelae, and usually precipitated by hyperventilation or photic stimulation, characterized by sudden loss of consciousness of short duration, and may be associated with high frequency, 50 attacks per day, falling to the ground without warning, jerky movements of head and upper limb. Myoclonic petit mal, drug of choice is valproate or succinimide. Myoclonic seizures, attacks of involuntary clonic movements, characterized by sudden, jerky, shock-like involuntary muscle contraction. Jerks are bilateral contractions, mainly of the shoulders and arms. However, some patients report jerking in the lower limbs, trunk, or head. It may be of two types: simple, occurs singly, no loss of consciousness, or as a part of petit mal epilepsy or grand mal epilepsy. Drug of choice, valproate or clonazepam. Atonic seizures, transient attacks of brief loss of postural tone, often resulting in falls and injuries. Partial seizures, excessive electrical discharges from the cortical neurons in a certain area in one hemisphere. We have simple, complex seizures. Simple seizures, no disturbance in consciousness, while the complex we have disturbance in consciousness. Simple seizures. Clinical picture depends on the site of the hyperexcitable neurons in the cerebral cortex, whether in motor area or sensory areas. Motor fits, focal fits, movement of part of the limb or the whole limb. Motor Jacksonian fits, movement of one side of the body. General sensory fits, focal fits, paresthesia of part of a limb or the whole limb. Sensory Jacksonian fits, paresthesia of one side of the body. Special sensory fits, visual hallucination, irritation of the visual sensory area, auditory, irritation of the auditory sensory area, olfactory hallucinations, irritation of the ancus. Complex seizures, disturbance in consciousness site. The hyperexcitable neurons are in the temporal lobe epilepsy. Duration, seizures last from few seconds to few minutes. It starts with aura, followed by absence, automatism, and amnesia. Aura, olfactory hallucinations, deja vu phenomenon, and sensation of fear. Absence, absent patient with staring eyes without any response to conversation. Automatism, involuntary, purposeless acts, motor, such as lip smacking, chewing, or verbal. Amnesia, no recalling of the seizure. Partial seizures or generalized seizures, they may spread to involve the whole brain, leading to secondary generalized seizures. Hysterical epilepsy, young neurotic females. The cause is psychological, no organic lesion. Incidence, it occurs in the presence of people, associated with anxiety, palpitation, and hyperventilation, not associated with tongue, biting, or incontinence of urine. Normal EEG. Precipitating factors of epilepsy, missed treatment, menses, alkalosis, alcohol use or drug abuse, cocaine, stimulation by photons and hyperventilation, sleep deprivation, and stress with sudden withdrawal of anti-epileptic drugs. Investigations, EEG. It shows specific pattern, epilepsy waves, the most specific test for epilepsy because it records the electrical activity of the brain. Local investigation, CT and MRI for the brain, to identify and exclude local cause of seizures in the brain. General investigations, laboratory investigations, to look for general cause of seizures, such as blood glucose. Treatment, general measures, moderation of the patient's physical activity, avoiding precipitating factors such as alcohol, hyperventilation, photic stimulation. Ketogenic diet encouraged to induce acidosis because acidosis raises the threshold of stimulation of the brain cells. Specific treatment of the cause in secondary epilepsy, anti-epileptic drugs. General rules for use, always start with one drug, then add another drug if there is no response. Stop the drug only if the patient stays free of symptoms for at least 2 years or the patient has normal EEG. Side effects of anti-epileptic drugs, skin rash, ataxia, bone marrow depression. Anti-epileptic drugs, phenobarbital, best indicated in broad spectrum and not for petite mal epilepsy. The dosage from 100 to 600 mg per day. Hydantoin, 100 to 600 mg per day, grand mal epilepsy and motor Jacksonian fits. Carbamazepine, 200 to 600 mg per day for grand mal motor Jacksonian fits, complex seizures, and not for petite mal. Clonazepam, 2 to 6 mg per day, myclonic and grand mal epilepsy. Valproate, 500 to 1500 mg per day, broad spectrum. Saxenamide, 500 to 1000 mg per day, and for petite mal epilepsy. Then we have new anti-epileptic drugs. These drugs are new drugs, may be used in resistant seizures, lamotrigine, felbamate, and gabapentin. Then we have status epilepticus. Definition: medical emergency due to repeated attacks of generalized convulsions with lack of recovery of consciousness or persistent attack of seizure lasting for at least 30 minutes. If the convulsions are not stopped rapidly, coma deepens and death may occur due to heart failure, respiratory failure, brain damage, or hyperpyrexia. The most common causes are sudden withdrawal of anti-epileptic drugs and stroke. Treatment, general measures, take care of ABC, place the patient on the ground to guard against falling from bed, mouth gag and oxygen inhalation, endotracheal intubation may be needed, record the vital signs regularly, take sample of venous blood for the level of anti-epileptic drugs and alcohol, arterial blood for the level of pH, oxygen, carbon dioxide, and hydrogen ions, give cerebral dehydrating measures, furosemide, concentrated mannitol, and dexamethasone. Specific treatment, phenytoin with diazepam or clonazepam immediately, phenytoin 15 mg per kilo slow infusion, diazepam 5 mg slowly IV, to be repeated after 5 minutes. If seizures recur, maximum dose 20 mg, or clonazepam 2 mg slowly IV, to be repeated after 5 minutes. If seizures recur, maximum dose 6 mg. If seizures persists after 20 minutes of phenytoin and diazepam, we give phenobarbital 200 mg infusion. In resistant cases, general anesthesia may be used. Multiple sclerosis or disseminated sclerosis. Definition: inflammatory disease of the CNS, brain, and spinal cord, affecting mainly the white matter in the form of patchy demyelination. Etiology unknown, probably autoimmune. CSF shows increased immunoglobulins, especially IgG, associated with other autoimmune diseases such as inflammatory bowel diseases or thyroiditis. Response to immunosuppressive drugs: the immune system attacks its own CNS, leading to demyelination. Antibodies occur against proteins in the myelin sheath surrounding the nerves. This causes inflammation, and injury to the sheath and ultimately to the nerves. This leads to multiple areas of scarring, sclerosis. The damage slows down the nerve signals, leading to impairment of the function. Risk factors: inheritance, genetic factors play a role. Infections, viral or bacterial infections may trigger the disease. Stress, physical and emotional. Surgery and trauma. Pregnancy, labor. Low vitamin D levels. Clinical picture: type of the patient, age from 15 to 45 years, sex more common in females than males, 2 to 1, behavior of the disease, onset, acute, course, commonly remissions and exacerbations, features, any of the following manifestations: mentality dysfunction, speech dysfunction, cranial nerve dysfunction, motor, sensory, cerebellar, autonomic, epilepsy, and finally heat sensitivity. Mentality dysfunction: depression, euphoria, emotional lability, cognitive impairment. Speech dysfunction: dysarthria, triple S, staccato, slurred scanning. Cranial nerve dysfunction, 2, 3, 7, 8. Optic, 2. Optic neuritis, visual loss, visual field defects, 3. Oculomotor, ophthalmoplegia, diplopia, internuclear ophthalmoplegia, 7. Facial, upper motor neuron lesion commonly, lower motor neuron lesion rarely, cochleovestibular, the 8th nerve, vertigo common. Motor dysfunction, paraparesis, monoparesis, hemiparesis, quadriparesis, and pseudobulbar palsy because it's for upper motor neuron lesion. Then we have the sensory dysfunction. The most common initial feature of multiple sclerosis, initially paresthesia, late, sensory loss or sensory ataxia, Lermit sign, electric-like sensation felt in the back, limbs on flexing the neck due to posterior column affection in the cervical region, cerebellar dysfunction, features of cerebellar ataxia, common, autonomic dysfunction, bladder dysfunction, urgency, most common bladder feature, incomplete emptying, bowel dysfunction, constipation, poor evacuation, incontinence, sexual dysfunction, impotence, and epilepsy occurs in 2 to 3% of patients. Heat sensitivity, it's called UFF phenomena. Small increases in body temperature can temporarily worsen current and pre-existing features. Clinical patterns: relapsing, remitting, 85% attacks which leave permanent deficits, followed by periods of remission, or less commonly, attacks which don't leave permanent deficits, followed by periods of remission, benign multiple sclerosis. Progressive, we have primary and secondary. Primary progressive, from the onset, continuous deterioration occurs with no periods of remission. Secondary progressive, initial relapsing remitting multiple sclerosis, which changes to continuous deterioration, occurs with no periods of remission. Progressive relapsing, steady deterioration since the onset with superimposed attacks. Other entities: clinical isolated syndrome, the first attack of a disease compatible with multiple sclerosis. Optic neuritis, exhibits characteristics of inflammatory demyelination but yet doesn't fulfill multiple sclerosis diagnostic criteria. Radiologically isolated syndrome, RIS, incidental brain MRI findings highly suggestive of multiple sclerosis in absence of signs and symptoms of the disease. Common features: sensory, visual loss, motor, diplopia, vertigo, and cerebellar ataxia. Investigations: fundus examination, pallor of the optic disc, CSF when MRI is unavailable or non-diagnostic, cells, mainly T lymphocytes, proteins, mainly IgG. The most important findings in the CSF: increased gamma globulins, especially IgG, and oligoclonal bands on protein electrophoresis in 95% of the cases. Cortical evoked responses, normally stimulation of any sensory receptor, visual, auditory, or somatosensory, evokes electrical sign in the corresponding region of the cerebral cortex. In multiple sclerosis, stimulation of any receptor evokes slow or abnormal cortical evoked response. Imaging, MRI, the most important investigation, confirms the diagnosis: patchy multiple areas in the white matter, plaques, or areas of demyelination. It differentiates new lesions from old lesions. Differential diagnosis: inflammatory diseases, Behçet, Devic disease, neuromyelitis optica, paraneoplastic encephalomyelopathies, sarcoidosis, transverse myelitis, and vasculitic diseases, SLE and PAN, infectious diseases, HIV, neurosyphilis, others, vitamin B12 deficiency, spinal cord neoplasm, ependymomas. Important points: multiple sclerosis is most common immune-mediated inflammatory demyelinating disease of the CNS. The most common features: sensory paresthesia, visual and motor paraplegia. Diagnosis: clinical criteria: MRI, brain and spinal cord, sometimes CSF and cortical evoked response. MRI is the most sensitive imaging test for multiple sclerosis. Treatment: we have to decrease the frequency of relapse and slow progression. Steroids for acute relapses. Treatment: immunomodulatory therapy or IMT. The value: to reduce the frequency and severity of the relapses and delay progression of the disability. Medications: we have the MEMS, disease-modifying agents for MS, currently approved by the FDA, interferon beta-A, beta-1A, interferon beta-1B, mitoxantrone, alemtuzumab, daclizumab, and natalizumab. Immunosuppressive therapy: MAC, methotrexate, azathioprine, cyclophosphamide, cyclosporine, and corticosteroids. Treatment of acute relapses: corticosteroids and plasmapheresis. Corticosteroids, methylprednisolone, give 1 gram IV infusion per day for 1 week, or STH, 80 international unit given IM per day for 1 week, then 40 international unit given intramuscular per day for another week. Continuous prednisone, 1 mg per kilo per day orally for 1 week, then taper gradually. Plasmapheresis may be of value in cases not responding to corticosteroids. Then we have symptomatic treatment and physiotherapy. Headache. Definition: mild to severe pain in the head, including front of the face and the back of the head. Etiology and types: vascular headache due to vascular dilatation or vasculitis, primary; migraine, cluster headache, temporal arthritis; secondary, hypertension, hypoxia, hypoglycemia, drugs causing vasodilatation, nitrates, toxins causing vasodilatation, alcohol and infections, bacterial or viral toxins; inflammation, intracranial, meningitis, encephalitis, neuritis of the sensory nerves of the scalp; trigeminal neuralgia, traction headache due to stretch of the meninges, increased intracranial tension, brain tumor, abscess or hemorrhage, post-lumbar puncture; muscle contraction headache, when one gets a stiff neck, the prolonged muscle spasm can compress the nerves and also induce ischemia with production of metabolites which stimulate pain receptors, prolonged driving, and cervical spondylosis. Referred headache due to diseases in different parts of the head: eyes, glaucoma; ears, ear infections; nose, sinusitis; mouth, dental sepsis. Tension headache, psychogenic. This is the most common cause. It occurs psychologically disturbed persons, usually females. I'm offended. It occurs pressure and band-like, bilateral, front to occipital. Criteria of serious headache: sudden, severe headache, headache associated with projectile vomiting and blurring of vision due to increased intracranial tension, headache begins after injury to the head, headache followed by DCL or associated with body weakness, headache associated with fever and stiff neck. Migraine. Definition: paroxysmal disorder characterized by intense throbbing headache, usually unilateral, associated with autonomic manifestations, nausea and vomiting. Etiology: idiopathic, genetic, heredofamiliar, 80%. Incidence: it's more in young females, female to male ratio 3:1. Residence in urban areas. Personality in perfectionistic people. Not offended. Migraine triggers: menses, medications, vasodilators, nitrates, and CCPs. Mental and physical exertion: meals, cheese, chocolate, citrus fruits, smoking, and alcohol. Clinical picture: it's divided into 2 stages. First stage is called the aura: visual, flashes of light, blind spots; sensory, paresthesia, motor, weakness. Second stage is the migraine itself. The second stage, it occurs in periodic and recurrent attacks. Site and reference: starts in the temple around the eye and then spreads to involve the whole side of the head. Character: pulsating or throbbing. Duration: lasting for few hours to few days, 3 hours to 3 days. Aggravated by bright light, physical and emotional stress. Relieved by sleep. Associations: nausea, vomiting, photophobia, and phonophobia. Pathogenesis: neurovascular theory, serotonin theory, and dopamine theory. Dopamine theory: recently, abnormal dopaminergic stimulation leads to headache of migraine and also causes associated manifestations such as nausea and vomiting. Serotonin theory: initial increase in plasma serotonin levels will cause constriction of cerebral blood vessels and reduction in cerebral blood flow, leading to the aura. Later, subsequent drop in plasma serotonin levels will lead to marked dilatation of the arteries. Headache of migraine. Neurovascular theory: vasoactive neuropeptides, migraine triggers, abnormal overexcitation of the trigeminal nerve axons, release of vasoactive neuropeptides, including substance P, from trigeminal nerve endings near the meningeal blood vessels, vasodilatation plus sterile inflammation. These peptides will cause vasodilatation plus sterile inflammation at the trigeminal nerve endings, spreading to the nearby meninges. Pain, resulting due to both vasodilatation and inflammation. Serotonin, through acting on its receptors, appears to block these peptides. Types: classic migraine, 25%, always preceded by aura. Common migraine, 75%, not preceded by aura, probably due to mild vasoconstriction stage. Rare variants: facial migraine associated with transient facial paralysis, retinal associated with transient decrease in vision, and finally hemiplegic migraine associated with transient hemiplegia. Treatment: during the attack, serotonin agonists and dopamine antagonists. Analgesics in size. Dopamine antagonists, we have metoclopramide orally or IV. Adjunctive therapy in acute attack of migraine. It relieves associated nausea and vomiting, antiemetic effect. Serotonin agonists, they act on serotonin receptors in the cerebral blood vessels, which were already dilated, leading to vasoconstriction and relieving the headache. We have selective agonists and non-selective. The selective, such as sumatriptan, taken orally, parenterally, or nasal spray. The non-selective agonist, we have ergotamine, taken orally, and it can be enhanced by adding caffeine. In between the attacks, prophylactic, avoid migraine triggers. Serotonin antagonists, such as mesaisargide and pizotifin, calcium channel blockers, sibirium and verapamil, beta blockers, propranolol. It prevents the uptake of adrenaline by the receptors in the vessel wall. The dosage, 10 mg 3 times per day. Beta blockers are the treatment of choice in patients whose migraine attacks are related to stress. Other measures, antihistaminics, antidepressants, and antiepileptics. Cluster headache character, attacks of severe headache starting on one side of the orbital and frontal region, spreading gradually to the same side of the head and neck. Duration, several minutes to 1 hour. Frequency, the attacks occur in clusters every 24 hours for weeks or months. Clusters are followed by long free periods, 6 months or 1 year. And this concludes our part for today.